Yes, this is Bill Boden, professor of medicine and preventive medicine, State University of New York at Buffalo Schools of Medicine and Public Health. Well, of course, we know that angioplasty and stenting is very beneficial in terms of alleviating patients' symptoms of angina. There had never been a prospective randomized study that had incorporated several well-validated questionnaires or patient-centered health status instruments as part of a trial like this, comparing angioplasty versus optimal medical therapy. So the intent or the hypothesis of this was that patients who underwent PCI, percutaneous coronary intervention, would have better angina relief and an improvement in their quality of life as compared with patients who received optimal medical therapy alone. And we recognize that probably the main benefits associated with angioplasty are for symptom control, as the main paper, of course, from Courage, I think, conclusively showed that there was no incremental benefit of PCI on top of a background of optimal medical therapy in reducing death, MI, stroke, or other hard clinical endpoints. Well, you may recall that Courage was really presented as a late-breaking clinical trial, and it was on a fast track for a simultaneous publication in the New England Journal in late March of '07. So we did all that we could at the time to get the main results of the paper presented and published. We knew that the quality of life data would be far more complex and really warranted a paper and deserved a paper on its own merits to have a more full and complete disclosure of the patient-centered health outcomes associated with the trial. No, there was nothing that was pre-agreed or pre-arranged. Through the discussions with the New England Journal of Medicine, they signaled their interest after the main paper had been accepted that they would be willing to consider a second paper that dealt with the quality of life and health outcomes. And so it wasn't until about late spring of '07 that we even got the analysis of the quality of life completed and submitted to the New England Journal of Medicine, and it's taken obviously well over a year for that to finally get into publication. My recollection is it was submitted sometime in May of 2007. It went through several peer reviews. Paper had to be revised several times. It was a very rigorous process. Dr. Weintraub, who's the lead author from Christiana Care, is the one who shepherded that through the completion process. The Seattle Angina Questionnaire, or the SAQ as we call it for short, has been very well validated in many randomized controlled studies. It's arguably the gold standard for assessing patient-centered outcomes as it pertains to angina frequency and severity. There are 5 domains associated with the Seattle Angina Questionnaire. They include physical limitation, angina stability, angina frequency, basically overall treatment satisfaction and quality of life. So those are the 5 metrics that are subserved by the 19-item questionnaire. And again, unlike the Canadian Cardiovascular Society assessment, which is in the main paper, that is to say, that's the physician's assessment of the patient's angina during the follow-up visits. The Seattle Angina Questionnaire and the RAN 36 form, or the so-called short form 36, the SF-36, are patient-administered questionnaires. So it really is a concurrent assessment of the patient's own perception of their functional health status. Yeah, it's a very good question. Essentially, all of the Seattle Angina Questionnaire domains are scaled from a 0 to 100 scale. So for, let's say, the angina frequency domain, you'd ask a patient, okay, during the last week or the last month, on a scale from 0 to 100, how would you scale the frequency of your angina? And so they would give you a number between generally 50 and 100. You'll note that the baseline Seattle Angina Questionnaire score for overall quality of life at baseline was about 51, which is a very low number. Low, a 0 would be, of course, very symptomatic, 100 would be asymptomatic. And so these patients were very compromised from a functional status standpoint at baseline. So what's nice about the Seattle Angina Questionnaire is that, as you're using it as a serial measurement tool with repetitive prospective measurements, and as patients obviously get accustomed to filling out the questionnaire, it's highly reproducible, from visit to visit. So it does give you a quantitative comparison benchmark for being able to track the improvement or the lack of improvement or the worsening in any of those 5 domains over time. Yeah, it's a good question, isn't it? I mean, intuitively, you would think that you would see the maximum benefit, let's say, in the first 1 to 3 months. Remember, though, that these are patients who had, on average, 26 months of antecedent angina, 5 to 6 episodes per week. There was a lot of clinical comorbidity. And remember, this was not a trial of PCI versus optimal medical therapy, but both groups got optimal medical therapy. So I suspect that there was probably an interaction between the benefits of optimal medical therapy combined with PCI, such that there was additive improvement in the PCI group that wasn't necessarily apparent at 1 month or 3 months, but became increasingly more prominent up to about 3 years, then it kind of peaked and tailed off. Well, I think to be fair, I think we have to say that, when looked at in a randomized comparison, PCI and stenting was better than optimal medical therapy in virtually every domain of the Seattle Angina Questionnaire for the first several months following PCI. I mean, that hardly comes as a surprise, because that's precisely why angioplasty is performed in the first place, to essentially decrease a functional stenosis and to improve, hopefully, symptomatic status of the patient. What I thought was rather surprising in the study, and I think all of us have been, struck by this over the last year as we've analyzed the results, is how well the optimal medical therapy patients did in comparison to the PCI patients. So we knew that PCI was going to win, in terms of its benefits in reducing symptoms, but we were really remarkably surprised to see how well optimal medical therapy did. As you'll see in this paper, most of the benefit associated with angioplasty and stenting disappeared after about 2 years. So there was an early benefit, but it was numerically small compared to optimal medical therapy. And again, in a study of almost 2,300 patients, sometimes small differences can be statistically significant. So for example, in some of these metrics, the difference between, let's say, the PCI group was a 76 versus a 73 in the optimal medical therapy group. While that 3 percentage points was statistically significant, it was numerically small. So that raises the issue of, whether these differences, are clinically meaningful or clinically relevant over the long haul. And again, I think the other observation is that the angina improvement or the quality of life benefit was not durable compared to medical therapy over time. That is to say, after about 2 years, there were no significant differences between the two groups, which paralleled almost completely what was observed in the main results paper a year ago, which showed that using the Canadian Cardiovascular Society assessment, that is to say, the physician's assessment of the patient's angina, there was the same early benefit observed for the first 1 to 3 years, and then after 3 years, the differences became less significant. In fact, were non-significant.